Laryngeal mask airway are used to ventilate the patients above the level of vocal cords. They are an intermediate between a face mask and an endotracheal tube. The main advantage of these devices are that they are less invasive for the respiratory tract, better tolerated by patients with increased ease of placement, improved hemodynamic stability, less chances of sore throat, and less coughing. They provide hands-free airway and easier placement even by the inexperienced personnel, along with a relatively secure airway. Contents: Introduction, History, Classification, Indications, Techniques of LMA Insertion. Introduction. They are known as supraglottic devices, extraglottic devices, or perilaryngeal devices, medical devices that are blindly inserted into the pharynx to provide a patent conduit for ventilation, oxygenation, and delivery of anesthetic gases without the need of a tracheal intubation. Airway devices that are intended to open, secure, and seal the supraglottic area to provide an unobstructed airway in the spontaneously breathing or ventilated patients, typically during anesthetic procedures. British physician and anesthetist Archie Brain developed in 1982. It was introduced into the clinical practice in 1988, clinically used in over 7,000 patients, and it was introduced in India in 1992. Classification. Based on the evolution of each device, the supraglottic airways or the laryngeal mask airways can be divided into first generation, second generation, and third generation. The first generation has the airway tube only. Second generation has additional designs that features to reduce the risk of aspiration. It has higher seal pressures to enable controlled ventilation at a higher airway pressure. It has an integral bite block to protect the patient's airway against occlusion. Classification. The first generation devices includes the simple airway tubes, example the classic LMA. The second generation devices are the ones with the additional drainage tubes, example ProSeal LMA and iGel. The third generation devices are cuffless and two drain tubes, example the Bhaskar Mask. Indications. It is used in securing the airway in CPR, in tracheal intubation, in failed face mask ventilation, and in failed direct laryngoscopy, failed intubation. Contraindications. It is contraindicated in patients whose mouth opening is less than 20 mm, in patients with full stomach, in patients with facial deformity, in local pathology of larynx or pharynx, or in prone position, and in increased risk of aspiration, as in morbidly obese, in pregnancy, and patients with daily gastric emptying. Advantages. It has increased speed and relatively easier to place. It needs less expertise. It provides improved hemodynamic stability during induction and emergence of anesthesia. It has minimal IOP and ICP changes, and it has increased airway tolerance. Disadvantages. There is more chances of aspiration, vascular compression and nerve damage, and sore throat. Most commonly used supraglottic devices: CLMA, classical LMA, PLMA, ProSeal LMA, iGel, and ILMA or intubating LMA. Classical laryngeal mask airway. It's a silicone mask. It is elliptical in shape. It is cuffed. It has an inflation tube, a pilot balloon, and a one-way valve. It has a shaft or the airway tube. It has a proximal and distal aperture bars that prevent the epiglottis from obstructing the ventilating lumen. It has an angle of 30 degrees. Methods of insertion. The LMA should be of the proper size. The cuff should be deflated. The water-soluble lubricant should be applied on the posterior surface of the cuff. The distal tip of the cuff should be in the upper esophageal sphincter, the sides of the cuff in the piriform fossa, and the upper part of the cuff on the tongue base. Pre-insertion, we inflate the pilot balloon and see whether the cuff is inflatable or not. Inspect for any cuts, blockage, or indentation in the interior of the airway. Kinking of the tube is present or not. We apply the water-soluble lubricant jelly on the posterior surface, for example KY jelly, before the insertion. Pre-oxygenation with 100% oxygen for 3 minutes, and patient should be given enough anesthesia using IV-inducing agent and muscle relaxant. The patient should be in standard head and neck position, that is cervical flexion and extension of the Atlanta-occipital joint. The LMA should be held in a pen-like fashion with the index finger placed anteriorly at the junction of the cuff and the tube. With the help of the index finger, push the mask gently against the hard palate and backwards, maintaining the backward pressure against the posterior pharyngeal wall, and fully insert the index finger for complete insertion. For confirmation, look for the chest rise and confirm with ETCU2 capnography. Other methods of insertion: 180-degree rotation reverse technique, insertion with cuff fully or partially inflated, laryngoscopic guided, used in tonsillar hypertrophy, high arch palate, large floppy epiglottis. Use of introducer. Other methods are jaw thrust, anterior traction of the tongue. ILMA or intubating LMA consists of an LMA, inserter and a reinforced tube. Select appropriate size, deflate the cuff, apply water-soluble lubricant to the posterior surface. Maintain proper head and neck position, neutral position, and patient should be in anesthesia by IV inducing agent and muscle relaxant, and it is introduced into the oral cavity holding the rigid handle parallel to the patient chest. Confirmation is by attaching the closed circuit and seeing the ETCU2 capnography. Disconnect the circuit and introduce the reinforced ET tube through it. Insert the tube till the horizontal black mark is seen. Attach the monitor and see the ETCO2. After that, move the ET tube slowly and keep seeing the ETCO2 levels till the ET tube full length is inserted. And after this, attach insertion rod to remove the ILMA and keeping the ET tube inside. Inflate the cuff and connect the circuit. Confirm by ETCO2. This video shows the slow insertion of reinforced tube through the ILMA. After ILMA removal, inflate the cuff and connect the circuit. Confirm it by ETCO2. Uses: in case of known difficult airway, in patients with known cervical spine injuries, ILMA use results in less spinal movement than direct laryngoscopy. It's a rescue device for failed intubation, that is, the can't intubate and can't ventilate situation. It can also be used as a rescue device for difficult bag and mask ventilation. IGEL. Parts of an IGEL. IGEL consists of a 15 mm connector, a proximal part of the draining tube, a bite block, an epiglottic rest, non-inflatable cuff, and a distal part of the drainage tube. Method of insertion of IGEL is similar to that of classic LMA. Pro-Seal LMA. It is designed by Archie Brain and introduced in 2000. It is a double mask over the entrance of the respiratory tract and over the gastrointestinal tract. Allows higher oropharyngeal seat pressure, about 30 to 40 cm of water during positive pressure ventilation. It has modifications such as esophageal drain, posterior inflatable cuff, an integrated bite block, and an introducer. Bhaskar Mask. It's an oval-shaped novel supraglottic device introduced in 2012. It's available in 4 sizes: 3, 4, 5 and 6 for adults. It has components such as cuffless membranous bowl. It inflates and deflates with each positive pressure breath during inspiration and expiration respectively. It's a tab. It helps to increase device angulation for easy negotiation of the oropharyngeal curve during placement of the device. The dual drainage system, that is an esophageal drainage inlet and a side channel to drain the pharyngeal contents. It has a bite block.